We start with the local examination. Inspection is done with the attitude, especially focusing on fixed flexion deformity at the ankle. Swelling around the ulcer is to be noted, deformity is to be noted and documented. Ulcer and its description is necessary. You have to document it, and the details is described in the next slides. Skin for cellulitis. Soft tissues, are they involved? Is it involving the bone of the foot? And lastly, condition of the heel and calcaneal tendon is to be noted. How to describe the details of an ulcer? It is described in several parameters. One is the size, length, width, and depth is to be documented. Whether the ulcer has got undermining or tunneling, its base tissues, how is the appearance of the tissue in the wound bed, whether there is necrosis or eschar in the wound, black, brown, or tan devitalized tissues that adheres to the wound bed or edges, and it is firmer or softer than the surrounding skin. Slough, granulation tissue, they are usually pink or red moist tissues. Epithelium, new pink and shiny tissue or the skin that grows from the edges of the wound or ulcer. Exudates is to be documented. Its amount, either none, slight, moderate, or copious. What are the types of the exudates? Is it serous, serosanguinous, or is it purulent? Order of exudate is to be documented. What is the age or the perimeter of the ulcer? Is it approximated, rolled, or calloused? Peri-wound skin for erythema or maceration is to be noted, or is it healthy? Presence of excoriation, denudement, erosion, papules or pustules around the skin, and also induration around the ulcer is to be noted. Remember, the abnormal hardening of the tissue is called induration, and usually it is caused by consolidation of the edema, and this is a sign of underlying infection. What are the phases of the wound healing? There are 3 phases usually: phase of inflammation, phase of proliferation, and phase of maturation. Inflammatory phase lasts for 0 to 3 days. The proliferation phase lasts up to 21 days, and whereas maturation phase lasts for more than 21 days, where tensile strength of the tissue improves. Coming to the palpation, the local temperature is to be taken, tenderness is to be assessed, and where all bones, all phalanges, metatarsals, tarsals, calcaneus, talus, and navicular. To understand especially the talus and the navicular, one has to understand its location or the anatomical landmark. All joints is to be looked for the tenderness, interphalangeal, metatarsophalangeal joint, ankle, Lisfranc joint, Chopard's joint. The ulcer is to be palpated, skin surrounding is to be palpated, calcaneal tendon tightness is to be palpated, and palpation is also done for surrounding edema. How to assess this Achilles tendon tightness? When there is a tightness, there is some confusion. Is it due to the tightness of Achilles tendon itself, or is the gastrocnemius muscle itself is tight? So, how to differentiate Achilles tendon tightness from the calf muscle tightness? And there is a test which is called silver scale test. It differentiates between the two tightness, Achilles tendon and the calf muscles. When you flex the knee, if the ankle dorsiflexion is increased, it means the tightness is in the gastrocnemius. And if even after the knee flexion, the dorsiflexion of the ankle is not improving, it means the tightness is in the Achilles tendon. Now vascular examination is to be done. Remember, atherosclerosis of the infrapopliteal segment is particularly common in the diabetic population. And underlying distal artery disease, when compounded by an infected ulcer in close proximity, may result in complete loss of distal collaterals and precipitate gangrene. And what are the reasons for the prevalence of this form of arterial disease in diabetic persons? The reason is following. There is high low density lipoprotein and very low density lipoprotein level in the diabetic persons. There is elevated plasma non-Willebrand's factor, inhibition of the prostacyclin synthesis, elevated plasma fibrinogen levels, and increased platelet adhesiveness. You have to do the color changes of the foot. Put the foot dependent, and is it causing purple red discoloration? Or you elevate the foot 60 degree for 60 seconds and see, is there any peeling of the skin? The distal pulses is to be assessed, especially the dorsalis pedis and posterior tibial arteries. And there are other signs of the arterial blockade is to be noted, which is skin atrophy and loss of pedal hair growth. In the segment of the vasculopathy, ankle brachial index is very important to be noted. Sensitivity of the ankle brachial index is 95% and specificity is 100%. Remember, in the case of non-compressible arteries in old days, it may not be accurate. So patients with either severely stenotic or totally occluded arteries may also have normal ankle brachial index if there is abundant collateral system present. The ankle brachial index is systolic pressure at the ankle divided by the systolic pressure at the arm. Let us understand what are the other importance of ankle brachial index. The ankle brachial index has been shown to predict mortality and adverse cardiovascular events independent of traditional cardiovascular risk factors. The major cardiovascular societies therefore advise measuring the ankle brachial index in every smoker over 50 years old, every diabetic over 50, and all patients over 70. Let us try to interpret the ankle brachial index. The normal range is 1 to 1.4. It means pressure at the ankle is usually higher than at pressure at the arm. Values above 1.4, it means the vessels are calcified and non-compressible. And the value below 0.9 is very important for us. It diagnostic of peripheral arterial disease. If the value goes below 0.5, still it suggests the same peripheral arterial disease, but in those situations, probably the patient will need vascular surgery. Let us understand why are nerves affected in diabetes. Vascular disease occludes the vasa nervorum. Endothelial dysfunction is present. The chronic hyperosmolarity causes edema of the nerve trunks, and there is effects of increased sorbitol and fructose, which inhibits proper function of the nerves. We'll come to the sensory testing. So, sensory testing, one is the nylon Siemens Westin monofilament test, where 10 touch points is assessed. There can be pinprick, position sense, also called proprioceptive sensation, vibration sense, 2-point discrimination test, and add to it the ankle reflex. Now let us understand the nylon Siemens Westin monofilament test. It is a 10 gauge monofilament nylon which is pressed against each specific site of the foot, and it is pressed just enough to bend the wire. If the patient does not feel the wire at 4 or more of these 10 sites, the test is positive for neuropathy. If the differential diagnosis, it is atherosclerosis, nerve lesions, chronic venous insufficiency. When we come to the investigation, the blood is investigated for the normal diabetes and its complications. Wound is investigated for the culture and gram staining of the bacteria, and imaging is done to rule out bone infection. Plain X-ray is good enough, that is most commonly advised. MRI only in suspected cases, it is not a common mode of investigation. Doppler is used to detect the occlusion of the vessels, and sometimes angiogram is done for doing the vascular surgery. Ultrasound, it is for detection of the deep-seated abscesses. Come to the management part. What are the principles of the foot ulcer management? It is divided in 4 segments: infection control, wound care, offloading, and vascular assessment. The general treatment is rest, elevation of the affected foot, relief of pressure, antibiotics, sometimes orthotics and prosthetics. But remember, the best treatment is prevention of the ulcer. How to do the infection control? Antibiotics is to be employed to control the infection. In superficial wounds, the topical agent is good enough, not likely to cause allergy and not associated with the bacterial resistance. And for the surrounding skin infection, topical agent, swab culture, and appropriate oral antibiotic. What is the protocol for deep wounds or osteomyelitis? Parenteral antibiotics is the choice of the treatment. How to take care of a wound? You have to cleanse it. Normal saline is supposed to the recommended solution for irrigation. Irrigation is done when the cavity wounds or tunnels are found, and they have to be irrigated with a force of 4 to 15 psi pressure to remove the debris without harming healthy tissue. More is the force, better is the removal of the debris, but they will harm the healthy tissue as well. So the force is remaining within 4 to 15 psi. Wound debridement is done. Debridement means removal of the dead or non-viable tissue from the wound. Why it is done? Because it removes the growth medium. Dead tissues are best medium for the bacteria to grow. And when the dead tissues are removed, it stimulates the healing process. And what are the types of the debridement? There are several types. Let us understand one by one. There is one autolytic debridement. It is the most conservative type of debridement. Debridement is a natural process by which endogenous phagocytic cells and proteolytic enzymes break down necrotic tissue. Of course, it is highly selective, where the necrotic tissue only will be affected in the debridement and not the healthy tissue. There is chemical debridement. It is accomplished by topical application of enzymes, say for example collagenase, papain with urea, and sometimes denaturing agents such as sodium hypochlorite. There can be mechanical debridement. It is usually carried using mechanical force, such as pulsatile lavage or wound irrigation. It will remove both devitalized tissue and debris, as well as viable tissues and healthy tissues. It is indicated for wounds with moderate to large amount of necrotic tissue. The contraindications, the most common one is if there is a granulation tissue which has got in higher amount than the devitalized tissue. So if this one is used, probably it will damage the granulation tissue. There can be biological debridement, which is also called larval debridement, also called maggot therapy. It uses sterile larvae of Lucidia sericata species of the green bottlefly. It is an effective mode of debridement, particularly appropriate in large wounds where a painless removal of the necrotic tissue is needed. It is bactericidal, as the larva ingest and digest bacteria. Inhibits bacterial growth by producing ammonia into the wound bed, which increases the wound pH and thereby decreasing the bacterial growth. It also breaks down existing biofilm at the wound bed, and it inhibits the new biofilm growth as well, and it directly ingests the necrotic tissues. There can be surgical debridement with sharp instruments done by the surgeons. So this is a type of debridement where the devitalized tissue, slough, necrotic tissues or the eschar is done in the presence of underlying infection, and they are removed using sharp instruments such as scalpel or curettes. And disadvantages include bleeding. It's called bleeding, or there could be disadvantage of certain complications from the anesthesia. Let us understand, can POP cast be a tool of treatment, or is it contraindicated in the diabetic foot ulcers? Appears that there is an ulcer, already infection, how to and why to put a POP cast there. But the truth is further away from it. Diabetic foot ulcers may be treated very efficiently with the POP cast, which is called total contact cast. The cast lets the ulcer heal by distributing weight and relieving pressure over the pressure points, and distributes the pressure over the entire plantar aspect of the foot. It is usually changed very often, every week or two, until the ulcer heals. How does it act? By relieving the pressure on the prominent areas of the foot. The cast is applied in such a way that the patient can remain ambulatory during the treatment of the ulcer. The principle involved is the cast is molded to the contours of the foot. Now, there are certain pressure points in the deformed foot, and the pressure is expressed in terms of force or pounds over area per square inch. Understand, if this force or the weight of the body which is on the foot is distributed over the larger area, then per unit or per square inch force will be lessened. So, if the weight bearing area is enlarged, the pressure per unit of the weight bearing area diminishes. And in this way, pressure which has been concentrated on bony prominences is distributed over the entire plantar aspect of the foot, allowing reversal of the mechanism that caused the ulcer to occur. What can be the newer treatment options? Can be bone aspiration. Bone marrow aspirate concentrate is made from fluid taken from bone marrow. And the bone marrow aspirate contains stem cells that can help the healing of some bone and joint conditions. And bone marrow aspirate concentrate is obtained with a minimally invasive procedure. Also, it can be used and being used in delayed union or non-union also, and sometimes in cartilage defects. The platelet-rich plasma injections are also a form of the treatment that can be utilized because they also have got healing factors there. And in case of acute limb ischemia, hyperbaric oxygen therapy may be employed. What are the surgery that can be done? Surgery is done to limb salvage and sometimes for amputations. So limb salvage surgical interventions can be angioplasty or surgical bypass surgery, where a newer form has come that is called subintimal angioplasty. Now, amputations can be done at different levels. Toe amputations, which is also called disarticulation, not usually done. Array amputation is most commonly done, where part of the metatarsal is also amputated along with the toes. Lisfranc amputation and choppers used to be done in the past. Now it is not done. Lisfranc amputation is when the amputation done at the level of tarso-metatarsal joint, and choppers amputation where it is done at the level of mid-tarsal joints. They both have problem with the complications, which is equinus deformity. After the ray amputation, most commonly employed amputation is the Symes amputation. So this is the Lisfranc amputation, and this is Chopard's amputation for the mid-tarsal joint. Not nowadays done commonly. Symes amputation is a preferred method of amputation, even though it is proximally placed in the Lisfrancs and the Chopards. It is disarticulation of the ankle, where heel pad is preserved and attached to the weight-bearing surface. In this particular Symes amputation, the requirement is there should be patent tibialis posterior artery. Symes amputation is more energy efficient than mid-foot amputations, even though it is more proximal, and it is used successfully to treat forefoot gangrene in the diabetes. Technique is medial and lateral malleoli are removed flush with the distal articular surface of tibia. The medial and lateral flares of the tibia and fibula are beveled to enhance heel pad adherence, and heel pad is secured to the tibia. This is the Symes amputation, and the heel pad, which is especially made for the weight bearing, is preserved and attached to the tibia. The patient can bear weight independently. Let's talk about the prognosis. Is prognosis only for morbidity, or there could be mortality as well? If there is a mortality, it is usually as a result of associated large vessel arteriosclerotic disease, especially the coronary or the renal arteries. Remember, the recurrence, even after successful treatment of a diabetic foot ulcer, is very common. It is 66%, and amputation rate rises to 12%. Now, some of the care for the diabetic foot you have to advise to a patient is stop smoking, never walk barefoot, examine foot daily, consult the orthopedician if there is any injury, examine shoes for foreign objects. Shoes should be immediately comfortable. Use the shoes with deep toe boxes. Do not wear new shoes more than 2 hours at a time. Rotate the shoes. Do not wear the same shoe every day. Never wear sandals or flip-flops. Lubricate entire foot if the skin is dry, but avoid putting cream between the toes. Do not soak the foot. Keep foot away from the heat sources. Don't use any tape or sticky products such as corn plasters on the foot. Do not file down, remove or shave calluses or corns yourself. Let it be done by medical experts. Do not use any chemicals or strong antiseptic solution on the foot. Trim toenails straight or let it be done by medical provider. Do not wear stockings or socks with tight elastic backs. And in the winter, wear wool socks and protective footwear. Thank you very much. We have come to an end. To go through this video a few times, I'm sure you will be competent to answer the questions posed by externals or the internals in any examination. Thank you very much.